चरक संहिता says, Nidrayat Sukha Dukkha Pushti, happiness or misery, nourishment or emaciation, strength and weakness, virility or sterility, knowledge and ignorance, life or death. All these occur in a person depending on proper or improper sleep. ह्याचं सूत्रस्थान आहे 21 ते 26 चरक संहितामध्ये. हे लक्षात घेऊन आज आपण सर्वांनी आजचा जो काही वेबिनार आहे तो लक्षपूर्वक ऐकावा. नाउ मे आय रिक्वेस्ट महा-IAP Women's Wing Co-Chairperson Dr. Neha Singh to say a few words and welcome the dignitaries.
Thank you so much, Chitra ma'am. Good evening, all my respected dignitaries, seniors, colleagues, for today's webinar on sleep disorder. Friends, we all know that sleep is a basic human need, but when the sleep gets disturbed, I mean to say the quality, timing, and the amount of sleep getting disturbed, ultimately leading to daytime distress and impairment of normal functioning of any person. So this is called sleep-wake disorder or sleep disorder. And this disorder is very important for all of us, whether it's infant, neonate, child, adolescent, or adult. Anyone can be affected. And it can be because of any medical condition and other mental health conditions like depression, anxiety, cognitive disorders, and many more. So today I don't want to waste time anymore, and I welcome all the my respected dignitaries who are present here for today's webinar. I welcome Dr. Hemant Gangulia sir, our immediate past Maha-IAP president, Dr. Mohite sir, our mentor, Dr. Pramod Wankade sir, immediate past Raigad IAP president, Dr. Vikas More sir, our present IAP Raigad president, Dr. Ajay Kohli sir, secretary. I can also see Dr. Abha Pathankar sir, Dr. Sunil Sheth sir, Dr. Kiran Vaswani ma'am. Thank you so much for joining for today's program. Now I hand over to our President, Dr. Vikas More sir, to introduce our first speaker and say a few words. Over to you, sir.
Thank you so much, Neha, for giving me this opportunity. First of all, I welcome all of you from on the behalf of AHA Raigad and IAP Raigad. And this is a very unique CME, very close to my heart. The initiative was taken by our very dear Dr. Sagar Varankar. It was his idea to have this CME, and it was supported by our Chitra Kulkarni madam. We know that the sleep is one of the essential component in the child health. We know that if you sleep at 10 o'clock, then the hormones like melatonin and serotonin are high. That's how you can have a good sleep, and it has a very wonderful effects on your body. But the moment you cross 12 o'clock in the night, the hormones like insulin and cortisol releases, and it has a very detrimental effect on human body. So the timing of sleep is extremely essential. It not only affects your health, it also affects your psychology. Even it says that even your looks are also dependent upon your sleep. I remember a story from our scriptures. A king called Muchkunda fought on the behalf of Devas, and Devas were very happy with him. They asked him to ask for a boon. So he asked them for a good sleep. You can understand, after waging a big war, he wanted a good sleep. So even from the ancient times, our Indian civilization endorses the importance of sleep. So on this note, we arranged this CME, very important CME. I am so happy that the stalwarts like Gangulia sir, Chitra madam, Mohite sir, Vaswani madam are present with us. And the respected faculties like Manisha Juvekar, Dr. Manisha Juvekar, Dr. Sagar, and Dr. Shilpa. They are presenting a very interesting topics, and it is a treat to hear to them for this topic. Initially, I introduced Dr. Manisha Zavekar. She is a practicing pediatric pulmonologist in Mumbai. And now she will be talking about the normal sleep patterns in children. So over to you, Dr. Manisha Zavekar.
Good evening, everybody. I hope I'm audible.
You are audible, madam.
Fine. Thank you very much to all the dignitaries and especially the IAP Raigad for giving us a chance to forecast and the newest topic, which we are actually getting aware, though we are still in the embryonic stage as far as sleep medicine is concerned. But I think we are slowly and steadily getting there. And once again, thank you very much to give me an opportunity to talk. So I think today's topic for me is about sleep physiology. So can I share my slide? Is it sleep?
Yeah.
Right. And to the I hope my slide is visible.
Yes. Yeah.
Thank you. So sleep physiology, I think sleep per se is like a magnanimous topic. So I will try and do justice to whatever little I can talk about sleep physiology, though it's a very vast topic. To begin with, the outline of my talk would a little bit on two lines about history behind sleep and the theories associated with what exactly was sleep because of, or like, what are the important theories behind people doing research on sleep. A little bit on physiology of the central nervous system of sleep, then what is the normal duration of sleep and what is the cycle of sleep, and then last but not the least, the most important function of sleep. Okay, so when I talk about the history, it is the Aristotle who investigated the concept of sleep. In the 18th and 19th century, initially sleep was thought that it could be because of lack of blood supply to the brain, or some people had had a research that it could be because of excessive blood supply, and the brain at this moment of sleep is supposed to be in the least active stage. That was the initial concept which was behind sleep. But later on, there was EEG, which was done by Hans Berger in the late 20s, in the 1920s, who proved it otherwise by doing EEG. And what they found on doing EEG was there was a lot of brain activity which could be demonstrated, and there were different patterns of brain activity, different EEG ways which were demonstrated in sleep and in wakefulness. So that obviously was a categorically evidence, objective evidence to show that actually the brain is most active during the stage of sleep. And it is not that the brain is sleeping during sleep. While there were different stages of sleep that we go through in the entire cycle of sleep, which was evidently proved by EEG. Now, control of sleep. As we know that we have a control of sleep, which is in the higher centers, the thalamus, the hypothalamus, the suprachiasmatic nuclei, the pineal gland, and other CNS regions. Now, if I have to just give a brief, I'm not going to go too much into the. Here you can see that you have the main important, or the part brain which usually controls is the thalamus. Now the other peripheral parts, that is the basal forebrain, PPT. So these are all peripheral portions which each individual organ has its own way of controlling sleep. Now here when we talk about sleepiness, as you see that when you see as night falls, the most important part of the brain which controls or puts us to sleep is called as the VLPO. The VLPO is the ventrolateral preoptic area. Now, what happens when there is darkness? Yes, melatonin increases. Yes, that is one concept. but this is the main part of the brain which will help you fall asleep. Now, what happens as night falls? This VLPO sends inhibitory transmitters to the other parts of the brain, and the other parts of the brain are basically put to sleep. So it is the VLPO, it is this tuberomammary, this is this ventrolateral preoptic area in the brain which is most active and which has got an inhibitory effect on the other parts of the brain, which puts you to sleep. Now, this is what happens during the night. Now, the contrary effect happens when it is a daytime. Now, what happens during daytime? Now, the VLPO activity starts falling. Once the VLPO activity starts falling, it is the other surrounding areas which are going to get overactive. Now, what are the other selective areas that you have which are going to be, start getting overactive? Is the other areas that you see the basal forebrain, the raphe nuclei, the other tuberomammary nuclei. So these all start getting activated. So the first area to get activated is the tuberomammary nuclei. And as you see, these dark parts which you see, which are circulating through the brain and the forebrain. So these are the histamine receptors which start getting activated. And that's precisely when you start patients on antihistaminic that they start getting little groggy, or we have a serotonin and 5-HT inhibitors which start making you very groggy and sleepy. So it is this area which starts getting activated first. The moment this area gets activated first, you see that it spreads like a wave all through the brain surface area, and then you start getting awake. So as you see here in this, eventually as the day starts increasing, you see that the other rest part of the brain start getting activated. The entire part of the brain, especially acetylcholine, histamine, serotonin, everything starts increasing, and there is an upsurge of all these elements with decrease in the VLPO, and that's how we wake up. Right now, the most important two processes that we say are important in maintenance of sleep. One is called as the hemostatic process, and one is called as the circadian process. Now, I'm sure all of us are aware of what is the circadian process. Now, this circadian process happens through the day, and there is a lot of waxing and waning. It controls the offset and onset of sleep. So it is a process which takes over a period of 24-hour cycle. Now, hemostatic process, it is a process which regulates your wakefulness, whereas circadian process is maintenance of sleep, and hemostatic process is a maintenance of wakefulness. Now, on an average, we need around 7.5 to 8 hours of sleep per night as we age. Or like I say, that in the adolescent age group. Well, this hours of sleep will depend again on the age of the child. Now, as I have said, now to have a little more understanding of what exactly is sleep-wake cycle. So here, if you see, the top process is called as the hemostatic sleep track. Now, as you see, as the day starts falling, and then it is a time for night. So it is just that your body tells you that it is time, and you have been awake for a long time, and then you need to fall asleep, and then you slowly start falling asleep. As you have covered up the sleep and your brain has covered up the sleep cycle, now it is time for the brain to wake up, and then again the whole cycle will start all over again. The same thing for circadian rhythm. It will start maintaining you during the day, and as night starts falling, it will start decreasing. At around 2 to 3 a.m., we have an upsurge of melatonin. The melatonin secretion starts way before the night falls, because once the melatonin secretion starts, it takes at least 2 to 3 hours for the body to start, for the surge to occur. And that is the reason that around 2 to 3 a.m., we are in that process where melatonin is at its peak. And that is when we go into the deeper stages of sleep. Now, as you see, the total sleep duration, like I have already mentioned, it again depends on the age of the child. The smaller or the younger infant and the newborn, as you see here, so they require almost 16 to 20 hours of sleep. And as you age, as you go in the adolescent age group and as you grow in the older age group, you see the duration or the total sleep time starts falling. Now, normal sleep cycle, as we say that normally sleep can be divided into two sleep states or two types, and it is a sequence which happens through the night. So this sequence happens through the night almost 5 to 6 times. So we have two stages of sleep. That is, one is the rapid eye movement and one is the non-rapid eye movement. Now, every 90 to 100 minutes, we go into the rapid eye movement of sleep. As you starts, as the night starts, going further and further, and as you are approaching in the early wee hours of morning, the REM stage will start increasing. So, if I have to just tell you, so this is basically the 4 different stages of sleep. In first stage of sleep, when you transition from being awake and you're just falling asleep. So this stage is in the initial very beginning, which will last for, maybe just 5 to 10 minutes. And at this stage of sleep, it is very easy for us to, awaken yourself. Then slowly we start going into the stage 3 of sleep. In stage 3 of sleep, the body temperature will start dropping, your heart rate will start slowing, and when you have, here you start losing your connection from the thalamus to the cortex, and then you start going into the deeper stages of sleep. Our body is in the maximum stage of sleep during stage 2. So stage 2 occupies almost 60 to 70% of our stage 2. Then slowly you go into stage 3. In stage 3, again, it is the deepest phase of stage of sleep, where it might be very difficult for you to wake up. If somebody has to wake up, it is with a lot of effort. And then you see that the most important parameters of your blood pressure, your respiration, or your breathing, everything starts falling, and it is the deepest stage of sleep. Once you have gone through these stages of sleep, the fourth stage that you reach is called as the REM stage. That is a rapid eye movement. Now, this rapid eye movement is the most active stage of sleep. It is when we actually start dreaming, and this is a moment where your muscles are completely paralyzed and you have rapid movements of the eye when you are in the dream stage of sleep. Well, so what happens, there is a lot of metamorphosis as far as sleep is concerned. So in newborn and infants, as we have seen, the circadian rhythm is very immature and it's not very developed. So they have very little differentiation between sleep and awake, day and night. That is the reason that because the circadian rhythm is not very well developed, these children can fall asleep, or these infants or newborn babies can fall asleep at any time. They can wake up at any time. The sleep duration can last for 1 hour, or it can last for 30 minutes. They're awake for a few minutes, for a few hours, and they can fall asleep. So basically, because of this imbalance, these children require long-term duration, but they don't sleep for very long hours. Okay? By the time, again, so like I said, in newborn period, the total sleep time can vary from 16 to 20 hours, and they do not have a clear differentiation of non-REM or REM, dream state. So these, at this stage, we usually label them as active or quiet sleep, and anything in between that is the indeterminate sleep. Now, these newborn babies, when they go, when they fall asleep, they don't go through the stage 1, stage 2, stage 3. They immediately go into the REM stage of sleep. Okay. And like I said, there is no clear differentiation at this age, which starts only after 6 months of age. Now here, in the newborn period, the sleep again depends on hunger or feeding and the and the nap time, right? As children grow and in the infancy, what happens is now the sleep starts getting more consolidated. Now, the nocturnal sleep can vary from 9 to 12 hours. In between, in the afternoon or in the late evening, these children can have small intermittent naps, which can vary from 30 minutes to almost 2 hours. So by 70 to 80%, most of the kids have sleep consolidated by 9 months. So like I said, by 6 months, they can, we can start getting differentiated into stage 1, stage 2, stage 3, and REM. So by the time almost 70 to 80% children have achieved this target by 9 months. Now, as children grow and then they are more, in the preschoolers or in the toddlers, you see that the total sleep time required is almost 10 to 12 hours. Most give up naps by 2 years, and now according to the newer guidelines, afternoon nap beyond 3 to 4 years is usually not advised. Here, this is a period when children develop night terrors or nightmares or separation anxiety, and they have a lot of behavioral related issues when it comes to sleep in the preschool age group. As the most difficult time happens in the adolescent age group. Now, in adolescent age group, what happens is they have what is called as a delayed sleep onset. Now, delayed sleep onset, the initial time, suppose if they used to sleep by around 9 p.m. or 10 p.m. or, whatever time they used to sleep, it starts getting delayed. It starts getting pushed ahead. So now they start sleeping by 12 o'clock, 1 o'clock, and this time starts getting advanced. Now, also what happens now, because of the school days, whenever they have school days during the weekday, they have normal sleep time and normal wake time. But this gets disrupted when they are in the weekend phase. During the weekend phase, they are, because of the constant, association with gadgets or, a friendly time or prep time. So these kids tend to advance their sleep time. So they start sleeping, very late and then waking up very late. And then again, there is a discrepancy in the circadian rhythm, and that is the reason that these kids can have a lot of behavioral issues if it is not adjusted accordingly, right? Now functions of sleep, if I have to say, now there have been different theories which have been put, like why do we really need to sleep? What is the function of sleep? What does sleep do? Which stages of sleep is important for what function? Now here they had this something called as a restorative therapy. Now, according to this restorative therapy, it was said that sleep is necessary to revitalize and restore the physiological process in rejuvenating the body and the mind. Now, these physiological functions are restored mainly in the non-REM stage of sleep. Now, what is the importance of REM stage of sleep? It is important for restoration of your mental functions. It is important to consolidate your memories. Whatever you have experienced through the day, it is in the REM stage of sleep that most of the functions get filtered and most of the important functions start getting consolidated. So the other therapy was called as the cognitive function therapy. In cognitive function, what they said, the important thing was, so every time there is any disruption of sleep, or you feel that there is a decrease in the sleep time, there is a disruption in cognition, and also because of this, there are deficits in memory. Now, because of this, also we have seen a lot of children who have cognitive deficit start getting symptoms, correlating with what we call as ADHD. Now, in these children, also they have done a research that these children have problems in decision making and they have a problem with long-term memories. Now, the other important thing is the energy conservation therapy. Now, what is the main function of sleep is to reduce the energy demand during a part of the day, that is during the night. Now, most of the studies which have seen the important metabolic rate, which falls to almost 10%, plus there is a lot of, there is a decrease in the other metabolic activities like your heart rate, respiratory rate, your renal function test, and the other systems are also at a lower rate. Now, even the body temperature, the calorie demand also drops during sleep. So this again supports the hypothesis that sleep plays an important role because it helps you to conserve a lot of your energy. Now, these are the effects, what happens in sleep. Now, whenever you are in the deep stages of sleep, there are a few changes which happen, and there are few changes which happen in the REM stage of sleep. Now, what happens to the heart rate? There is a decrease in heart rate with the decrease in cardiac output associated with 5 to 10% decrease in the blood pressure. Also, there are many hormones, especially like growth hormones during sleep, which can, there'll be an increased secretion of growth hormone. During sleep, the most important part, which we have to be very careful, and this is one of the commonest abnormality that we've seen in children with central sleep apnea, children with neuromuscular diseases, or children who have restrictive lung pathology or any central nervous system problem. So in these children, what happens? There is a decrease in the ventilatory response to hypoxia and hypercapnia. So every time there is a lot of CO2 buildup, these children cannot generate their own breathing pattern, and that's how they present with central apneas or obstructive sleep apneas if they have any breathing related issue. Now, also they have seen that there is a decrease in the renal blood flow, the GFR falls, and decrease in the urine output. The main important aspect about the CNS being involved, there is a decrease in the parasympathetic and there is a decrease in the sympathetic tone. Now, what are the ill effects of sleep debt? So there is something called as sleep debt. So sleep debt is something which you are trying to, there's a lot of accumulation of sleep related issues, or there is a lot of sleep which has been lagging behind. And that is what the body tries to cover, but it is unable to cover. Now, what are the ill effects of sleep deprivation that we have seen? What happens is there's a lot of depression, mood swings, poor concentration, fatigue, forgetfulness. Now, of late, what we have seen in children who, retrospectively, now we have gone and seen patients or children who present with ADHD. And retrospectively, when you ask them that, if the child has snoring problems or is the child having a lot of sleep fragmentation, does he wake up too many times in the night or does he snore? Listen, that is the time that parents actually come out and tell us, yes, the child has not been sleeping very well. Every day in the morning, he's very groggy, very irritable, or he's continuously tossing and turning in the middle of the night. So these are the common symptoms, but they come out only when you inquire about it or when you have a mindful of this, symptom. So these children, we can have short-term memory problem. There is irritability, learning difficulties, and long-term problem like obesity, diabetes, cardiac problems, dementia, thyroid-related issues. And obesity, as we say, could be a cause or an effect of sleep disordered breathing. Like I said, sorry. So like I said, the most important aspect of dealing with sleep has been because of these detrimental effects, not only just on psychological, but also on mental and physical well-being of children and adults as well. Right. So I think if I have to just summarize that, what we wanted to, I had to be little brief on what is the sleep physiology, the work, what is the function of the sleep and requirements at every age, the different stages of sleep and different cycle which happens, and what are the effects of sleep deprivation. So before I end, so since we have our level 1 sleep study lab, and like I said, it's a little difficult topic to cover everything in just 15 to 20 minutes. But since Dr. Sagar and I have been cumulatively working on our level 1 sleep lab, so I would just give there's just a 2-second video, if it is all right, if I can just show the video of what exactly the kind of work that we do. Okay. Is that okay?
Yeah.
So this is our sleep lab in New York.
Manisha, just explain while it's going on.
Yeah.
That will be better.
Dr. Manisha, how the procedure is done, that also you can explain.
Yeah.
Sorry, let me stop it.
Okay, fine.
Yes. Thank you.
Can you explain in brief?
Sorry, ma'am, I didn't get the question. I didn't hear. Yes, ma'am.
Okay, later on.
Hello.
Shall
it's
we go
okay.
to the next talk then? Thank you, Dr. Manisha, and it was a very informative session, basic of the. Now I request Raigad IIP Secretary, Dr. Ajay Kohli, to introduce our own Raigad IIP member, second speaker, Dr. Sagar Varankar.
Hello.
Hello.
I think I just stop sharing.
Hello. Am I audible, Doctor?
Yes.
Yeah. Can somebody share the slide?
Yeah, Dr. Neha is sharing.
As good evening all. Now we come to the second topic, and the speaker is no stranger to us. He is our very old respected Dr. Sagar Varankar sir, our go-to man for any respiratory and allergic problem. Sir is a practicing pediatric pulmonologist in Navi Mumbai and Panvel area. Sir, he has done after post-graduation, he has done European diploma in pediatric respiratory medicine. He has done diploma in pediatric sleep medicine from the Colorado University, and also diploma in allergy, asthma, and immunology. Sir has many publications to his name. Over to you, Dr. Sagar. Please begin the presentation.
Yeah.
Thank you.
Dr. Manisha, can you stop sharing?
Yeah, she has.
Why mine was not visible? So she is still having,
No, sir.
No, Dr. Sagar, she has already stopped sharing.
She has stopped sharing. Even Dr. Neha has also stopped sharing. You please go ahead. Start your presentation.
Yeah, I'm not able to share. That's why.
Sagar, log out and log in again. Yeah, I think you're good.
Is it okay?
It's coming. Yeah, it's okay.
Yeah.
Go ahead.
Okay, fine. Am I audible?
Yes, sir.
Okay, fine. So thank you so much, my family members, Raigad IIP, for giving me this opportunity to talk in front of you all. And so World Sleep Day comes on 17th of March every year. So I just put that idea of, putting something about the sleep to all my Raigad IIP friends and my seniors. So we thought, let's introduce this year at least somewhat about the sleep to all of you. So first topic was the physiology and basic about the sleep. So now I'm going to talk about the sleep disorder breathing. So what I have observed in last 8 to 9 months, that after the corona pandemic, I am seeing a lot of children are coming with large adenoids and snoring, breathing difficulties, upper airway syndromes. So this topic is very, very important. Last 7, 8 months, maybe my practice had changed because of maybe post pandemic. I started seeing a lot of adenoids enlargement, and or maybe I have done the sleep course. That's why I thought maybe I'm seeing a lot. But let's go through it. So sleep disorder breathing is so overview of my talk will be sleep disorder breathing. What is exactly is the obstructive sleep apnea? What are the risk factors and clinical presentation? How do you diagnose and how will you manage? And also how this sleep disorder breathing is interrelated with the asthma as well as the obesity. So pediatric sleep disorder, if you see, divided into 4 quadrants mainly. One is insufficient sleep quantity, one is disruption or fragmented of sleep, that is poor sleep quality, inappropriate timing of sleep period, that is circadian sleep wake disturbance, and primary disorder of excessive daytime sleepiness, that is called as EDS. So we are going to talk about disruption and fragmentation of sleep, that is poor sleep quality. Yeah, so sleep disorder breathing is characterized by snoring and or abnormal respiratory pattern during the sleep. So it has got wide range, like just having a primary snore and having the obstructive sleep apnea, which is the highest form of sleep disorder breathing. So primary snoring we tend to see very often in pediatric age group as well as in adults. Sir, हमारे family में तो सबके सब snoring करते. That is the common comment you hear once you ask the parents that is your child is snoring at night. Then they say yes, हमारे family में तो सब snore करते. इसके पापा, इसके दादा, इसकी. So that is called as primary snoring. So how will you differentiate between obstructive sleep apnea and primary snoring? We'll come to know in further slides. So if you see the definition of snoring, it is a vibration of oropharyngeal soft tissue due to breathing against increased upper airway resistance during the sleep, and which is very, very commonly seen, almost 30 to 40% in children. What is habitual snoring? If this snoring is more than 3 times in a night, 3 nights in a week. What is primary snoring? If this habitual snoring without any ventilatory abnormalities like apnea, hypopnea, or gas exchange or arousal, we call it as a primary snoring. And what is sleep disorder breathing? Is nothing but it's a syndrome of upper airway dysfunction during sleep that characterized by snoring or increased respiratory effort that result from increased upper airway resistance or pharyngeal collapsibility. So if you see the obstructive sleep apnea syndrome, you will see there will be upper airway obstruction due to adenotonsillar. So it's not obstructive sleep apnea is not only it's not only adenotonsillar hypertrophy, not only because there is a choanal atresia or chronic nasal obstruction or mouth breathing, not because only obesity and overweight, but this is commonly present in our day-to-day practice. And of course, craniofacial abnormalities like Down syndrome and other syndromes like mucopolysaccharidosis. This is a major chunk which we see. But as a pediatric pulmonologist and a respiratory and a sleep specialist, I do see this category, that is neuromuscular disease and hypothyroidism. That is reduced upper airway muscle tone, and that can cause obstructive sleep apnea in these children. The treatment is totally different in this group. And of course, there is a reduced central ventilatory drive, that is Arnold-Chiari syndrome, or myelomeningocele, or brainstem injury, or masses like cerebral palsy children. So we run a neuromuscular clinic in SRCC hospital. There I see a lot of neuromuscular like SMA kid, Duchenne muscular dystrophy, mucopolysaccharides, and of course brainstem injury like cerebral palsy. And somewhat it's a genetical or hormonal also. So what are the risk factors for obstructive sleep apnea? Gender, mostly common seen in boys. Prematurity, yes, of course, 3 to 5 times more likely to develop OSA, cause unknown. Environmental factors like tobacco smoke or any exposure associated with environmental exposure to the smoke increase the risk of OSA, and that is what is happening right now in Mumbai. And when I talk to my friends from other part of India, most of them are saying that like in Delhi and Bangalore, most of them are telling me that there is a rise in OSA in a lot of urban population, and that is mainly because of lot of air pollution. And Mumbai is being a second polluted city in the world. I'm seeing every day at least 30 to 40 cases of OSA now in my practice. And of course, obesity, adolescent obesity is on the rise. I'm seeing a lot of patients with obesity with OSA, almost 4 to 5 times increased risk can be seen. And genetic positive family history, as I already mentioned, almost 22 to 84%. And of course, medical condition like craniofacial syndrome, neuromuscular disorders, Down syndrome, achondroplasia, mucopolysaccharides, cherry malformation, Beckwith-Widman syndrome, all these Prader-Willi syndrome. This is commonest thing which endocrinologists send to me: laryngo and tracheomalacia, subglottic stenosis, asthma, severe allergic rhinitis, and of course, sickle cell diseases. Let's see what are the consequences of OSA. So we see a lot of patients with OSA, familial OSA, not OSA, but primary snorers. But is there any really requirement of anything to be done, and why it is so? So if you see the consequences of OSA, what ERS task force report says, there is a major effect on cardiovascular system in the form of development of systemic hypertension, and of course the pulmonary hypertension is common because of lack of oxygen. Metabolic like insulin resistance, lipid dysregulation, and metabolic syndromes. And of course, central nervous system like behavioral and neurocognitive in the form of aggression, impulsivity, hyperactivity, and of course, neurocognitive in the form of language and academic difficulty. I have not put the video, but I have video of parents, a father telling me about all these features develop after this. So this is commonly seen nowadays, maybe because of lot of social media uses, as well as a lot of, in fact, screen time. And of course, children were more of autistic features, autism like features, autism like disorder are coming up in post-pandemic situation. In the children, we see a lot of OSA also. So what this total comprises of OSA syndrome, where there is a either of cardiovascular, metabolic, or central nervous system consequences in obstructive sleep apnea patient. So what are the clinical presentation? There are nocturnal symptoms like snoring more than 3 nights per week, and it should be allowed and frequent, and sudden gasp or apneic pauses observed by parents, and of course paradoxical movements of and restless sleep, sweating. This is commonest presentation with which parent come. डॉक्टर एसी लगाते हैं फिर भी बच्चे को है ना रात भर पसीना पसीना रहता है. Of course, mouth breathing and drooling of saliva. In daytime symptoms, as I already said, chronic nasal congestion because of maybe adenoidal enlargement, rhinorrhea, hyponasal speech, that is nasal twang, morning headaches, excessive daytime sleepiness, mood change, ADHD-like symptoms, and academic and learning problem is commonly seen in adolescent. And of course, most important, associated features like anuresis and growth failure can be seen very frequently. So I just wanted to show you one video. This child was, I think you can hear. This is a severe form of OSA.
Sound is not there.
No, we are not able to hear it.
No, not an issue, but I can explain. There is so much snoring, and because of severe obstructive sleep apnea, you can see the child is literally sitting and sleeping. The child came from Mulund to me, and look at the way he's sleeping. Like that, there are so many kids, facing post-pandemic this issue. So literally every day, the child will have this issue. This is another kid came to me. They told me that this they were treating for asthma. They were treating for with MDI, and the child, you can see. You can see there is a subcostal sternal retraction, and there is a lot of snoring. You can see the suprasternal retraction. I think I'm not. So a lot of sound will come. So this is very extreme form of I am showing, but there are so many with with minimum also we see in everyday day-to-day practice. So how will you evaluate these children when come to your clinic? So clinical history and physical examination is very important. Medical history in per se, allergy, rhinitis, asthma, GRD, and frequent URTI is very commonly which are we are seeing last 8 to 9 months. And of course developmental history because of CP children. Prematurity, as I mentioned, almost 20 to 40%. Family history of snoring and behavioral assessment is very important. I remember sending patient to Shilpa for this similar issue. And of course, validated questionnaire are there, but they have poor sensitivity and specificity. But pediatric sleep questionnaire, if you Google it, you will get it freely on the Google. This is that in all these validated questionnaire, this is better than anything else, which has got sensitivity of 72% and specificity of 72%. It correlates better with moderate to severe, not in a mild variety. And physical examination, you have to see whether there is a growth failure and obesity, and hint like head, eyes, ear, nose, throat. So to differentiate craniofacial abnormality or deformity, and of course adenoid facies. Signs of atopic like allergy salute, shiners, nasal cavity for septal deviation, polyps, oropharyngeal examination like tonsillar size. So this is high arch palate, very important. And of course, tonsillar size, Brodsky score and Mallampati score is very important. Chest, if there any V's, cardiac, blood pressure, and to check for loud P2, and CNS neuromuscular abnormality is very important. Retrognathia is very commonly seen. I mean, children with retrognathia have a lot of tongue falling backward, and they can have uh, obstructive sleep apnea in the children. So what investigation you will do? Lateral chest, lateral neck radiograph. Nowadays, commonly I'm asking for because of too many kids coming with these issues. It helps not the so that's water view, not the frontal sinus X-ray. If you want to do, you can do lateral neck radiograph to find out how much is the adenoidal, and so even though it just to show the parents, not it has got good sensitivity but poor specificity, but just to show parent, even if it is there is no adenoidal hypertrophy seen, but you can still do it. Nocturnal video recording, which is very essential nowadays, and everybody has got smartphone, they can definitely do it, like these parents which I have shown in last videos. And if not possible, we can do flexible endoscope for evaluation of upper airways, nocturnal pulse oximetry, drug induced sleep endoscopy, which is commonly done. I'll show you one video I have done for one kid, and overnight polysomnography, which is the gold standard. So we have Philips Sleep Lab Alice 6, which is the gold standard for level 3 sleep lab. And yes, of course, cardiac complication, we can do ECG and echo. So this is one nocturnal pulse oximetry. I have this Massimo machine where I can give it to parents, and then they can do this just for initial evaluation. Until unless we do PhD, we can't help. But sometimes, so in USA and in developed country, we have actigraphy. It's nothing but a Fitbit watches. So nowadays studies are going on that also. You give Fitbit watch or anything like actigraphy to the child and see how much is the on that, how much is the requirement of polysomnography, and if required we can start on that report also. I'll not go into detail of that. So drug induced sleep endoscopy, which is something coming up, it's nothing but we make the child sleep like is natural, which mimic the natural sleep in endoscopy room. It's for diagnostic and planning for surgery. Sometimes, not every time you have to do it. It's especially in a persistent OSA after tonsillitis. So that child which I showed who sat and was sleeping, he has undergone the adenoid removal almost 1 year back in Hinduja hospital, and he came to me even though after that. So he had very bad asthma also. So for this, we can do drug-induced sleep endoscopy, that is called as DICE study, where we can see the nasal, oropharynx, hypopharynx, and larynx for mobility and Malaysia and epiglottis. So this is one of the scoring for DICE grading scale, where we can say how much is the obstruction seen on this DICE study. So this is one video I want to show you. You can see there is a so much of collapsibility in this child. Um, as well as there is a laryngomalacia, and of course he had very bad you know you can see the adenoids falling, as well as he has got pharyngomalacia as well as laryngomalacia. So with this we can plan the surgery. Just removing tonsils and adenoids is not going to help. And of course polysomnography, which is the gold standard, and there are definitions like when you call apnea, when you call obstructive apnea, when you call sedentary. I will not go into detail, but ASM has given the guidelines how to diagnose OSA. So accordingly, severity score, if you do OSA score, mild when we call apnea hypopnea index 1 to 5. So even one index is called as mild. We can wait and watch for some time. Then of course the moderate, that is 5 to 10, and severe more than 10. So this is the study I have done. I think in last September. This is a Prader-Willi kid, and he was just 2 years. This child came to me, sent by endocrinologist, because they wanted to give growth hormone for this kid. So after doing this study, we could tell them you can just go ahead with the your growth hormone therapy, and we will observe the kid. No need to remove adenotonsils right now, because so this is done in Juvekar lab. So I have, me and Manisha has kept that lab in Chembur. And of course, diagnostic criteria for OSA. Uh, if you go clinically, presence of snoring, more than one, that is snoring, labored or paradoxical, or obstructive breathing during sleep, sleepiness, hyperactivity, behavioral problems, or learning problems, either of these. And in B, if there is more than one obstructive apnea or mixed apnea or hypopnea per hour of sleep. And of course, PCO2 more than 50 mm of Hg in association with either snoring or flattening of respiratory nasal waveform and paradoxical thoraco-abdominal motion, we can call it as a OSA, and we can put label mild, moderate, and severe. So how do you manage? So indication for treatment, as I mentioned, primary snoring, just annual evaluation, require no treatment. If HI more than 5, irrespective of presence of morbidity, we have to treat. If HI, that is mild one, morbidity present, we need to treat. Or if there is aneurysm, growth failure, a decreased quality of life, risk factor for persistent SDB, you treat them. Treatment is priority in presence of major craniofacial abnormalities, neuromuscular disorder, and Down syndrome, because anyhow neuromuscular children are, they required BiPAP or CPAP, depend on their condition. If pH not available, treatment can be considered based on positive oximetry and PSQ in presence of morbidity. So the treatment option, as I said, depend on severity of symptoms, duration of disease, and of course the host factor. Age more than 2 years, we can directly go for adenotonsillectomy. There is no need for now waiting for 6 years, 7 years. So I tell my parents, if they ask me, doctor, लेकिन हमारे पीडियाट्रिशियन ने, हमारे जो डॉक्टर ने बोला था कि ये बहुत जरूरी है, then I tell, see, adenoids and tonsils are there for everyone. They are like our rakshak. But अगर हमारे रक्षक ही हमारे भक्षक हो रहे, in the sense, if they are causing so much of trouble in child's life, then I think it's better to remove. And there are certain, so before surgery, always we do sleep study in this patient. So surgical intervention in the form of adenotonsillectomy, rapid maxillary expansion. So inside one lab is there in Bandra, where we do, where we can send, I send a patient. I remember Chitra madam has sent one me patient, and this patient gave me so much information, because they went to Dubai, then they came back, and they have done this rapid maxillary expansion. Madam, if you remember this Muslim patient, and uvular paratopharyngoplasty, craniofacial surgery, tracheostomy. In non-surgical, of course, if the child is obese, we need to look for the weight loss. And of course, CPAP, BiPAP machines are available. If after adenotonsillectomy, also child is having severe symptoms. And of course, there is a contraindication like a neuromuscular. So we do adenotonsillectomy. But in this patient, if they are still want to wait, we can go ahead and start BiPAP and CPAP for this patient. And pharmacological, if there is association with allergic rhinitis and there is a mild to moderate OSA, you can try for montelukast, that is leukotriene antagonist, for 2 months, and of course nasal corticosteroid if there is a allergic rhinitis, and of course anti-GR measures, because this patient will have a lot of gastritis and GR because of they can't sleep at night, and they develop gastroesophageal reflux commonly. Adenotonsillectomy, nowadays they are doing coblation, no laser treatment. Most of them, they come and ask, but doctor, wahan pe to laser treatment available hai? No, coblation is the best treatment available and done everywhere. And as I said, more than 2 years, you can definitely go for it. Success rate ranges from 24 to 100%. And that is the reason before doing adenotonsillectomy, we do sleep study, because we can predict whether the child will have post-surgery also, he may require some treatment or not. And then we can, of course, tell. Otherwise, if you directly say and do adenotonsillectomy, then parents ask, doctor, even after surgery, my child is suffering. So post adenotonsillectomy, we usually follow them regularly for 6 to 12 months, because there is chances of 20 to 40% of persistence of disease. Risk factor like male sex, obesity, if there is a moderate to severe OSA, persistent tonsil hypertrophy, and American Academy of Sleep Medicine recommends follow-up or PHG post adenotonsillectomy after anytime in between 6 weeks to 12 months. So this is the stepwise approach. As I mentioned, recognize OSA. If it is male obesity, then you can do oximetry or you can do polysomnography. If there is indication for sleep disorder breathing, you can stepwise approach like weight loss, nasal corticosteroid. If there is allergic rhinitis, give montelukast. It has got good results. And of course, after that also, if there is no improvement, we can give adenotonsillectomy as an option. You can give a rapid maxillary expansion or orthodontic appliances. And if there is a neuromuscular issues or something craniofacial abnormalities, then you can go for CPAP or BiPAP or non-invasive ventilation. And tracheostomy in very severe tracheomalacia or bronchomalacia. So recognition and management of persistent sleep disorder breathing after adenotonsillectomy and later also is very, very essential part. So this is a girl with, she's a very famous girl. She has got a YouTube channel. She's a Kea with SMA type 2 kid. After doing sleep study, we have immediately put her on BiPAP and she's doing fantastic. So this is Philips Respironic giraffe mask, which is very, very helpful for this kid for treating this kid for nighttime during nighttime sleep disorder breathing. It helps. They increase their life expectancy, of course, and as well as their life. It changes their life totally. So sleep problem in asthma, as I said, sleep disorder breathing is very common. You see in asthma, they get hyperactive because they can't sleep at night. So you have to think about the adrenal hypertrophy, obesity, other factors, and of course drugs which we commonly use that can cause again sleep problem in asthma. So it has got tremendous impact of asthma control on sleep problems, and of course association of symptoms with if you treat properly asthma, control properly, sleep disorder breathing reduces. But still some amount will be always there. There is a 4.5 times increased risk of sleep disorder breathing in children. So short sleep duration in the children. So obesity is, of course, independent risk factor for sleep disorder breathing. So we have to work combinedly with a nutritionist and, of course, therapist and as a pediatric sleep specialist. There are multiple, so I'll not go in detail. So they're more prone. So first treatment will be adenotonsillectomy with their enlarge and weight reduction. And by the time child will attain this weight loss and all these issues, weight loss. Until that time, we can always ask them for CPAP because until unless we start CPAP, there might not be having a weight loss in this period. So take home message: children should be screened for habitual snoring. Early diagnosis and treatment can prevent long-term consequences. PH is gold standard. Nocturnal oximetry questionnaire will help you, as well as clinical features. Adenotonsillectomy is the first line of treatment for pediatric OSA. Watchful waiting for 6 months in mild moderate cases is okay. Sleep disorder breathing should be screened in asthmatic children, especially in uncontrolled and severe asthma. And of course, obesity is a significant risk factor for persistent OSA. So guided weight loss complement with the non-invasive therapy, which is a complement therapy, will help the children to sort out this problem. Thank you so much.
Thank you. Thank you, Dr. Sagar. And it was very informative, detailed, elaborative, various elements which are there for these snoring kids. And now we will go to our third presentation. A study has published in Indian Journal of Pediatrics in 2019, and they found that poor sleep quality and sleep disturbances are there with late night use of mobile in Indian children. To throw more light on this subject, may I invite our young and enthusiastic developmental pediatrician, Dr. Shilpa Nambiar Gandhi. She has done her DCH in Amrut Medical Foundation and trained under our academic guru, Dr. Mahesh Mohite, and presently working there. Over to you, Dr. Shilpa.
Thank you so much. Thank you so much, ma'am. Good evening, everyone.
Please share your presentation.
Yes, ma'am. Is it visible?
Yes.
Yeah.
Can we make it full screen?
Yes.
Yeah. Thank you.
Good evening, everyone, and thank you so much for giving me the opportunity to be speaking on this very important topic, which is affecting the mental and physical health of many of our children and adolescents in this day and time. So we will be seeing how sleep affects the child growth and development. My talk can be considered as a short summary of what we learned today and healthy sleep habits, which also we should follow as we preach. So as we saw, adequate sleep is a range of time and not one specific hours, and it changes as our age increases. By 6 to 9 months, as ma'am had already mentioned, by 6 to 9 months, an infant understands day and night cycle. By early childhood, we see reducing in daytime naps with proper nighttime sleeping. Daytime night naps at this age specifically is very important for memory consolidation, executive attention, and motor skill development. Preschoolers, they have other issues like attachment issues, separation anxiety, frequent night wakings, and independent locomotion, which leads to reactive co-sleeping. And bedtime resistance is also seen in them. School children usually start to have a inherent circadian rhythm, which can be either taken as a morning time sleeper or a nighttime sleeper. And both are fine. We should follow a goodness of fit, which suits the child and the family, and it can be done until and unless they sleep at a proper time. When we come to adolescence, it is the time of increased independence, emergence of new social roles, They wish for autonomy. There is a shift in family configurations, peer culture increases, increase in academic demands, extracurricular activities increases. So staying up late at night, sleeping, waking up early in the mornings for schools. And then there is a catch-up sleep, which they do in weekends especially. So this happens in the nighttime. So post-COVID, how has the sleep pattern changed? So if when there was a statistic taken, 70% of the children, they had delayed their sleep time by almost 60 to 90 minutes. Around 60% of the children, they go with mobiles or some tabs before going to sleep. And only 45% of them have a follow a proper bedtime ritual. How this sleep disorder is affecting their study is almost 70% of the children complains that they cannot pay attention in studies because they don't have a good previous night's sleep. 65% of them don't feel fresh or happy when they wake up in the morning, and 65% they sleep during the online classes 1 to 3 times a week, which is very different this thing. So how does the sleep affect the physical growth? As Dr. Sagar sir has already mentioned, there is a very direct correlation with weight and sleep loss. As we sleep less, our hunger hormone increases, ghrelin increases, and we crave more for junk food, and thus increasing the weight of the child. Weight in obesity directly increases the risk for type 2 diabetes, cardiovascular risk factors. Our immunity also goes down, which affects our health, and frequent infections happen. It also affects our mental health in a way that in our body, metabolites like adenosine is what causes us to become drowsy. But when we let it accumulate more and more and don't sleep much, it decreases the neurogenesis, thus affecting the brain in its growth, and learning and memory impairment, cognitive problems happen. So it affects the whole gray matter in a whole, which leads to poor logical conclusion. The child has lack of imagination, difficult doing new tasks, making connections, slurred speeches, hallucination, or blurred vision. All this can be causes. So it can be divided as, in short term, we can see the child is complaining of difficulty concentrating. There's a decline in the mood, impaired vision, fatigue. And long term, it affects the overall performance of the child, cognitive decline, academic, poor scholastic scores. So this picture, basically in the night when the child is with a smartphone or a gadget, it may be for their studies, it may be for chatting or surfing or watching something. It has a very negative effect on the sleep. So the light emitted from the devices usually suppresses the melatonin secretion, which leads to difficulty in sleep initiation and also the maintaining. The constant shift between weekday and weekend, where the child tries to catch up, it impairs the corticolimbic function of the brain. Thus, it increases the reward gaining behaviors in a child, and the reduction of cognitive control. They together increase the risk of addiction in adolescents mainly. So it's a vicious cycle of sleeplessness and mental health issue or anxiety, any whichever we put it up. There is lack of sleep, there is an anxiety. Anxiety again causes to lack of sleep, and it goes on and around. So why it is so important to discuss? Because according to the latest statistics, 1 in every 4 child suffers from a sleep disorder, which is a huge amount. Around 6 out of 10 children in middle school and 7 out of 10 children in high school don't get enough sleep. So what should be done? It is very important to have a healthy sleep hygiene for all of us, not only the kids, but for the adults. So coming back to adolescents and children, so sticking at a same bedtime and waking up at the same time every day, even on weekends, is very important. Beds are only for sleeping. No other activities like watching movies or eating or doing your school projects should be allowed on the bed. It has to be a comfy, cozy room. Giving our cultural this thing, we have a lot of constraints, but we have to try to make this a point that we emphasize on. A good bedtime routine should be formed, which has to be quiet, calm, relaxing activities. Avoid caffeine intake after late afternoons. Put the kids to sleep when they are drowsy but awake, and maintaining a sleep diary. So in infants, we can easily see for sleep clues like rubbing of eyes, yawning. These kind of clues that the infant gives shall be a sign for the baby's sleep and should be addressed to. Promote self-soothing in infants and train the infants to day and night differentiation. So some behavioral techniques which people can try in infancy is unmodified extinction, which means the child is placed at the bed at a predetermined bedtime and ignored till the next morning. It is like baby cries to sleep, which most of us don't believe in our culture, but it does help. Then graduated extinction. It is the same as the above, but with regular scheduled check-ins, you can check on the baby. Then is preemptive waking schedules. Many of the children, they have after a few minutes, after a few hours, they try to wake up. So when you know that the child wakes up around this after this much time, you can 15 to 20 minutes prior to that, just wake the child up and then use some relaxing, soothing activities to make him to sleep again. So this, when done repeatedly, will help the baby sleep for longer duration. In preschoolers, the parents have to limit settings. How much time the child can spend on the mobile, at what time the child has to go to sleep, what activities the child has to do before sleeping. Avoid co-sleeping, relaxation techniques. Some deep massages can be given, deep breathing exercises can be done with the baby. Use of imagination and creativity. You can read a book for the child, make some drawings, ask them to count sheep or just make a picture of someone. So, and this helps in sleeping. In a school-going child, the child should be given the opportunity to set the limits, not the parent. So the child decides how much time will he take for the homework, how much time is he going to watch the TV. And school-going child should spend some time in outdoor sport activities every day. If a child has difficulty in sleeping at this age, faded bedtime can be used. It means that a child has to go to bed at a predetermined time. And if he sleeps within the first 15 minutes and gradually, slowly increase the time to the time you desire. Faded bedtime with response cost is as above, but if the child does not sleep within the first 15 minutes, you have to wake up the child, make him engaged in some other activity for the next 30 minutes, and after that, again, let the child go to sleep. So the basic idea is the child has to sleep within 15 minutes. The bed is for sleeping and not for other activities. In case, because at this age, we also see a lot of phobias, anxiety, then maybe the child needs CBT. In adolescent stage, as we saw, there is a huge change in their daily activity. It is still very important to maintain a regular sleep schedule. If the child has some work on weekdays, so they are not supposed to catch up on the weekends. They have to get up at the same time as they did during the weekdays all the days. So this helps in maintaining the circadian rhythm. Naps only if very sleepy, that too only in the early afternoons and 30 to 45 minutes, not more than that. Spend time outside, exposure to sunlight to help the internal clock be on track. Exercise regularly is very important. No screens on the bed has to be followed. Bedtime routine like taking a bath, listening to music, reading a book, these can be inculcated in their daily routines, daily nighttime rituals. avoid coffee after caffeines after late afternoon, caffeines including soda drinks and everything. Eating regular meals and avoiding heavy meals just before going to bed is very important and has to be done during the adolescence stage more, because we tend to eat more and the cause of obesity and everything goes on. So if these are the few healthy sleep hygiene which can be followed by a child to have a healthy sleep routine. And that's it. Thank you. We are not discussing anything pharmacological over here.
Yeah, thank you very much. And you have touched a sensitive part in the childhood sleep pattern, which has changed tremendously. Now it's time for question and answers. Dr. Neha, any questions in chat box?
No, ma'am. I cannot see any question. But anyone if in the attendees can ask their questions if they want to.
Okay, it's already late. We are nearing for the successful completion of this sleep. Yeah.
Ma'am, I have a question for Dr. Sagar, sir. Sir, as you told, because of hypothyroidism, there can be sleep disorder. But can you tell me how? What is the percentage for like if child is coming to me for sleep disorder? What is the percentage I can they can be hypothyroid? And what are the causes for it? If the child is not obese, only hypothyroid.
Sir, please unmute. Dr. Sagar, please unmute.
Yeah. Can you hear me?
Yes, sir.
So hypothyroidism per se, it's not necessary just to have, as I told you, that 3 circles. Okay. So there in hypothyroidism, there might be a large term that can cause obstruction when falling back. That can cause sleep disorder breathing. That is one commonest one. Second is because of hypothyroidism, there will be a lot of muscle weakness in the pharyngo and as well as laryngeal muscles, and that can cause, when they are breathing, there can be a lot of vibration, and that can cause sleep disorder breathing.
Okay, sir. So if any patient is coming to my OPD, I'm not a sleep specialist, but before referring to you, can I go for thyroid investigation?
So it depends. If you feel that he is obese and looks like on his face, looks like might be hypothyroid, or he is, nowadays every child who comes to our OPD and parents say, Doctor, आजकल खेलता नहीं, बहुत घर पे बैठा रहता है. We know that could be because of, post-COVID, they are used to, sitting at home and watching TV. So it's up to you clinically. If you feel that this child is having hypothyroid and if he's having SDB-like features, then you can definitely go ahead and do the test. Not necessary for just snoring. Yes, you can just keep and watch, ask them, take a video, how much he's suffering. Those things should be, kept in mind before doing any investigation. So it's not just all hypothyroid you have to do. Just keep that in mind.
And when should we send any patient refer any patient to sleep specialist?
So I have already mentioned that if there are in 3 consequences, like is there any so most commonly if there is a high blood pressure associated with this, any craniofacial abnormality, or if there is anything like CP child or DMD child, usually they come from neurologists, but anything like this. And of course, a child who is having symptoms in a daytime, like hyperactivity, inattention, autistic child, doctor, I can't sleep, last so many months I have not slept. That is the commonest complaint parents tell us, because he doesn't sleep. Just now Shilpa has mentioned very nicely the sleep hygiene. If after doing that also, if child is not improving, then definitely we need to go ahead and do the sleep study in the children.
Thank you so much, sir.
Thank you. Mohit sir wants to ask something.
Not really. just a comment, maybe you can say. The list of symptoms they mentioned about sleep disorder, I'm sure presently I'm seeing 23 people, and at some time it was 40 plus. So at least 80% of us are having these disorders going by the symptoms. And that's mainly for sleep deprivation. And I believe bigger problem today is not obstructive sleep apnea, it's a deprivation. Even the small children who come with those chronic symptoms going for months and literally six months. And they get up, child बच्चा खेलता नहीं है, वॉमिटिंग करता है, दिन भर करता है, सुबह के टाइम में करता है. Go into slight more depth of the symptoms, and you realize this child sleeps at 12 o'clock, gets up at 5:30 in the school, and then he has to be really moved to go to the school, and then the whole problem start there. I think it's a lifestyle disorder. That's we need to focus. I agree. OSA is a problem. Another thing, many times the ENT surgeons recommend to remove the adenoids just looking at the X-ray, which is a very past science of more than a decade ago. Today, as Sagar clearly said, and even Manisha said, it's a sleep study which has to confirm that that adenoids are causing some obstructive problem. Just because they are seen on the X-ray with more than 50%, as I said, it's got a poor sensitivity and or rather poor specificity and high sensitivity. I think sensitivity is by virtue of symptom. There's no symptom related to that. Just because it is coming with a large mass, it really doesn't mean that you have to remove it. Absolutely. So we need to do a sleep study to confirm. That's today's science. We'll see many of the ENT surgeons are recommended the baby and they come to you for the second opinion as a pediatrician. So I think as a kind of policy matter, with the present available evidence, subject them to sleep studies and confirm that they are, because many of those patients just with the nasal steroids, they settle down. I can tell you almost 8 out of 10 who are recommended for removal of adenoids, they have settled down just with a good, nice doses of nasal steroid and proper hygiene. So just kind of a point. I think rest everything is absolutely wonderful. Thank you.
Thank you, sir.
Hello.
Yes, Dr. Vikas.
There should be one more CME that how to sleep better while being a pediatrician.
Do you have time to sleep? Do you have time to sleep?
We are all sleep deprived.
Sagar is taking his CME, but I never. He's always there, like taking rounds at 2 o'clock in the night and 4 o'clock in the night. So he's one of the most sleepily deprived person in the Raigad district.
Agree totally. Now may I request our AHA Raigad Joint Treasurer and First Lady of Raigad IAP, Dr. Sanjeevani More, to express our gratitude for this CME and the dignitaries.
Thank you, ma'am. First of all, I want to thank to our adolescents because of whom we are there on this digital platform. Thanks, Dr. Manisha Juvekar, ma'am, Dr. Sagar, sir, Dr. Mrs. Gandhi for an excellent speech. I thank Dr. AHA President, Dr. Kulkarni, madam, IAP President, Dr. Vikas More, sir, Secretary, Dr. Kohli, sir, for arranging such a wonderful seminar. I thank Dr. Neha for conducting such a smoothly way. Specifically, I thank Dr. Mohite, sir, for your guidance and valuable presence, sir. I thank Dr. Gangulia, sir, Pramod Wankhede, sir, Abasai Patankar, sir, Dr. Vasani, madam, respected senior colleagues and dear friends. Thank you so much for attending, sir.
Yeah, and also Dr. Vishal for supporting this CME.
Thank you so much.
Thank you so much.
Thank you. Thank you very much.